Thank you for your invitation. And I have two presentations. I present my topic, and after the topic of Dr. Michel Henry. I showed some clinical cases. I would like to demonstrate the effectiveness of the MFM in the treatment of aortic aneurysms and type B dissection. I have no disclose. Our Moroccan series include 21 aortic aneurysm and 6 type B dissection. No surprise in demographic, except one case of tuberculosis and one case of syphilis. All the procedures have been done under local anesthesia. The mean duration procedure is 1 hour for aneurysm and 1 hour 30 for dissection. On the right side of the slide, we can see how we deploy the MFM, the bigger into the smaller, and from bottom to the top. We have treated the 11T AAA with the mean diameter of 74.4 millimeter. And we have also treated the 10 AAA with the mean diameter is 67.8 millimeter. The box plot shows for the both aneurysm that the major ejection occur at 1 month. And when you compare the progress of diameter, we can see that at 6 months, the mean difference of diameter is higher for transversal diameter than anterior-posterior diameter. The ratio analysis show that the ratio of thrombus volume, total thrombus volume increase, while the ratio of residual flow volume decrease, showing a continuous thrombus formation in the leading to the aneurysmal sac exclusion. We have 8 cases with the long-term follow-up, 5 aortic aneurysm and 3 type B dissection, follow-up between 5 and 10 years. The first case concerns a young female with tuberculous aneurysm, and this is the CT scan at different level of on different level and until the 18 months. At 5 years, the patient developed type 1A underleak, and which has been corrected by secondary procedure. And this is the CT scan. 6 months after the secondary procedure, we can see that we have the totally the exclusion of the aneurysmal sac. This is the CT scan until 10 years. And we could see at this aneurysm before the implantation of the procedure, and at 10 years we could see the evolution of the aneurysmal sac. Also in the transversal slide. And at the same level, we can see the evolution of this aneurysmal sac before the implementation of the MFM. And at 10 years, we could see that the aneurysmal sac is completely excluded at this level. The second case concerns a patient with the aneurysm of the top of part of the descending aorta. And this is the CT scan at 5 years after in the follow-up. In the 5 years, the patient developed a triple AB iliac aneurysm, but the iliac aneurysm, the aortic aneurysm is in the 48 millimeter, and we decided for this patient a close monitoring. This is the CT scan before and at 5 years. This patient have for this patient the aneurysm is not completely excluded. We'll see that the aneurysmal sac can take several months to be excluded, and the speed phenomenon is in a relationship of the diameter of vessel efferent, and here is the left subclavian artery she drew from this part of the aneurysm. The triple A and at 7-year follow-up, and we could see the lumbar patency for in the reconstructed images at this level. We have also treated the 6 type A dissection before we created an animal model which ruptures at 2 days without treatment, And we see on the top the explant at 3 months with the stent in the true lumen and the false lumen completely thrombosed. The finite element analysis showed that the MFM converts turbulent to laminated flow in false lumen, global flow is reestablished, and the false lumen size is reduced. To evaluate the evolution of the dissection, we do 3 measures at the proximal, medial, and distal region for the true and false lumen. This case is it's a woman known type B dissection and the medical treatment. 1 year after that, she complained by back pain, and the CT scan showed the increasing of the false lumen and dysplastic aspect of the left subclavian artery, SMA, and celiac trunk. We decided to treat both branches and aorta. This is the CT scan at different levels and different time of the follow-up until 5 years. This slide summarizes the constructed images before and at 5 years. This is the CT scan before and at 5 years. You could see the evolution of the false lumen. The second case is the patient with type B dissection and huge left iliac aneurysm at 130 millimeter. And we can see the evolution at 4 years. And we have the reduction of the false lumen, and the iliac aneurysm is completely excluded. The numeric simulation showed that the speed, flow, and pressure reduced in the false lumen after implementation of the MFM. And on this graph, we could see that the false lumen volume for this patient is in regression. And this is the CT scan before the implantation and at 5 years. Unfortunately, this patient died at 7 years in the follow-up by car accident. We have technical success for all the procedure. We used between 1 and 7 MFM, and we have no neurological complication despite covered aortic length, and all the branches remain patent. One does not related stent at 7 years, 2 corrected endoleak, 1 type 1A at 5 years, and type 3 at 6 months, 1 PAD leading to fem-fem bypass at 2 years, and appearance of nephropathy at 4 years for diabetic patient. The MFM is easy to use, means simple procedure with less radiation, shorter procedure, shorter hospital stay, less complication, leading to better clinical outcome. The global MFM registry highlights the success of the MFM technology with 0% mortality at 30 days, 0% rupture, 95% side branch patency. And the MFM is proving its safety and efficacy also in the French study at Strato at 4-year results. The MFM is a proven technology. Over 7,000 patients treated worldwide for aortic and peripheral aneurysm. Different studies for the aortic and dissection reported by different countries. But to have the good results, we must observe instructions for use. Thank you for your attention.
Thank you, Dr. Amira. That was a great presentation. Great to see you. And hopefully we'll see you also at 40S. Just a simple question. If there is a coexisting severe osteal, renal, or celiac, or other major branches stenosis, how do you deal with that?
We must treat the stenosis of the branch before the implementation of the MFM.
Okay. And that may include putting a stent also, or you put the stent afterward?
And after that, in the same time, you place the MFM.
Okay.
Yeah, please. I can speak, please.
Yeah, you can, please.
Congratulations for my friend Amira.
Hi.
I hope that you are well. I think the most important advantage of multilayer stent is the patency of visceral arteries after implantation. We treated 42 in Oran in Algeria. We treated 42 patients with ventilator stand, a patient with aortic aneurysm, thoracic aneurysm, or thoracoabdominal aneurysm. And the follow-up is, I think, 5 years, the mean of the follow-up 5 years or 6 years. 15 patients were lost for follow-up. 7 patients were dead. 3 deaths were related to the aneurysm, aortic aneurysm. And for the rest of the patients are well for the moment. It's our experience in Algeria.
Merci beaucoup, Professor Amira. Great presentation, and it's good having Rodney with us as well. Because I remember when the MFM came up, and it was like dream comes true suddenly, because it was like we can treat everyone, and it's so simple, and it's so low risk, and it's just amazing. And I jumped into the MFM with Sheriff Sultan in Ireland, and to me, it looks like it works perfectly for small vessels, for a small diameter sized, aneurysms. But unfortunately, it doesn't really work well in the aorta from some reason. It's not very clear to me. Perhaps Rodney or Zonko or Professor knows to comment better on this.
If I may add, we used wall stent, which was 2 or 3 wall stents together, which is very similar to multi-layer, even though some of the believers and proponents of multi-layer think it's a totally different thing. The point is that you have a very small opening between the stent struts with 3 wall stents, similar like you would have it with a multi-layer. And we reported our first experience in 1998. And then another experience in 2000, and after that again. And what we have found in infrarenal abdominal aortic aneurysm, that it is true that you develop thrombus. And it's very effective in most of the patients, but not in all of them. And I'm talking about aneurysmal disease, not dissections. But in patients that have a very pronounced flow through the lumbars, and there are 4 pair of lumbars, and the inferior mesenteric, those vessels stay open, as it has been clearly shown with multi-layer stent. Now, when they stay open, the blood has to flow from the lumen of the aorta, new lumen, which is created by stent, through thrombus to the lumbar and inferior mesenteric artery. The blood is traveling through clot. This really never endothelializes in a clot. So you are dealing with endotension. And this is why it doesn't work well in large aneurysms. Now, we have seen that in cerebral circulation and so on, that a lot of those patients that have saccular aneurysms, and that's also true for abdominal aneurysms or iliac aneurysms, it works very well. But when you have atherosclerotic aneurysms with a lot of branches coming off, in most of the instances, it doesn't work well. Even though it worked well in an animal model, because Carlos Ruiz published that information in the very early 90s, and he showed that in sheep and pig model, those stents endothelialize very fast, but a pig and sheep model is totally different than a human model. So that would be my criticism for the use of multi-layer stent in atherosclerotic infrarenal aneurysms in most of the instances. Now, I would like to ask Amira, obviously this multi-layer flow modulator stent doesn't have a tremendous radial force. And when you're dealing with dissection, where you have a compromised true lumen, let's say you have compromised flow to the mesenteric and visceral vessels, I have a feeling that this stent does not have enough of radial force to expand the true lumen. Of course, it can thrombose the false lumen, but still the true lumen remains relatively compressed. Can you comment on that?
We saw the first volume lumen ligation, but the diameter of the of the true lumen. When we put the MFM inside, we deploy the MFM in the landing zone, proximal and distal of the dissection, and we expand the MFM, and we see that in the follow-up we have the expansion of the MFM, and the volume of the true lumen began to be normal after that, but in the long time.
Yeah, I think that's what Victor has shown also, that they expand over time. There's a couple of cases where he's dilated it with a balloon, but I think, Dronko, that concern you can deal with. Your point about the aneurysms, and again, I don't know whether the IFU needs to be adjusted or not, but it says clearly in aneurysms not more than 6 centimeters. And again, the aneurysm part of that data needs to be fine-tuned better, but that's where people have had trouble, like it was mentioned, ruptures late in a large aneurysm. So, but in the dissections, the data is really impressive. So that's kind of the overview. I don't know if Amira, you agree with that or not.
Yes, multi-layer stent is not indicated for a big aneurysm. I think that's, when the diameter is more than 6.5 millimeter.
Right. Well, the IFU says no more than 6. Now, I don't know if that's the exact size, but yeah. And as you said, people have reported ruptures in aneurysms that are bigger than that, because it does, as Ronco said, it's laminated thrombus. And some of the measurements that I looked at the core lab data, it depends on whether you're measuring the size of the aneurysm or the size of the flow lumen that's left after an aneurysm with the clot. And there's confusion between the two of those too. So I think there's more work to be done there. And Jonko's right, and you also, again, in the big aneurysms, it's been problematic. I think people have seen that. So in the aorta, the peripheral vessels seems to work fine.
It's very obvious that what you highlighted is a big difference between the indication to use the MFM. And there is a big difference between using it for the triploid or aneurysmal disease and for the dissection.
Yeah.
But in a dissection, as long as we don't close the inflow into the false lumen, like how does it work? How is the Zvonko? You mentioned that it behaves completely differently in the dissection. What is your experience with the dissection, aortic dissection treated by MFM?
I don't have experience with aortic dissection. It's not available in the United States, so I only looked at the information from the literature and the properties of this particular stent.
Amira's got lots of data. Victor also. I have done cases with Victor because I was skeptical in the beginning. Ted Dietrich was the one who convinced me to look at it, and we spent time in Europe. But in the dissection cases that we followed up, the side branch patency, and really no paraplegia has been a big. I think that's a big advantage that where it could be used. And again, the aneurysm data, somebody's going to have to look at that and refine it. So.
But Rodney, this is what I understand. The best is that you can keep flow into the branches. That's clear. You obviously perfuse the lumbar, so the paraplegia risk is very low. But also you keep the flow into the false lumen in that case, no?
Well, it expands like Amira, like Amira said, that device will expand over time. Now, it doesn't, in all cases, completely eliminate that, but in the majority, and I don't have data to tell you the percentage of it, but it does increase in size and the false lumen regresses. And as Amira mentioned, again, I've done a couple of cases with Victor where it was very narrow, and some people dilate it in order to get an immediate increase in the flow. So I think that, answer yours and Zranko's concern about that. You can place it and dilate it acutely to get rid of part of that false lumen.
So probably the type of the flow in the new stent decrease the pressure in the sac and probably decrease the expansion of the sac because the flow now luminar, so that may be less pressure on the sac afterward, even though there is blood, but not really too much pressure in there.
Well, that's the theoretical advantage, and I don't think anybody's confirmed again what size in the aorta is appropriate. But
did they put any pressure sensor in any of those stent to see what happened, or
not that I'm aware of, no.
Yeah,
Amira
cardiac
might
did it. Cardiatis did it. Sensor pressure in the aneurysmal sac, and I think there was a study about that.
Yeah, but not for MFM. Yeah.
For MFM, yeah.
Okay, I think because of the paucity of time, is it okay that Amira finishes Dr. Henry's talk as well? Dr. Henry
Sure.
not make it because of some personal reasons. So Amira has to be giving that talk. It's again on MFM, but it's on peripheral aneurysm. So it's quite in context with aneurysmal disease.
Okay.